Thank you for joining us today. My name is Andrea McNeil, and I'm a surgeon at Vancouver General Hospital and a clinical associate professor at the University of British Columbia. I'm also a member of the Cascades Executive and the founder and principal investigator of the UBC Planetary Healthcare Lab, which is one of Cascades' founding partner organizations. Now, before we start, I'd like to take a moment to acknowledge and reflect on the lands from which we're all gathering today. Cascades operates coast to coast, and as a result, we're living and working on many different lands, which are the traditional territories of many different First Nations, Métis, and Inuit peoples. I myself am joining today from the traditional territory of the Musqueam, Squamish, and Tsleil-Waututh peoples. If you're unsure, I would encourage you to learn about the people who are the traditional caretakers of the land where you are now. As we begin today's discussion of changes to systems of practice, I would also like to invite each of us here to take a moment to reflect on our own practices and what actions we can each take toward reconciliation. Today's session is the third of 3 webinars coordinated by Cascades in partnership with organizations from across Canada to reflect on the implications of Canada's commitment to the COP26 health program. At the last United Nations Conference on Climate Change, the Conference of the Parties in November in Glasgow, Canada signed on to the WHO Health Program, which called for countries to commit to delivering climate resilient and low carbon sustainable health systems. This series is a chance for us to come together with colleagues across the country to ask what that means for us and what comes next. We started the series in January with an introduction to the commitment. In our February session, we dug into the issue of climate resilience and what we will need to do to address the growing challenge of climate change. Today, we're exploring a high-level roadmap to low-carbon healthcare situated within the COVID context. We are joined by 3 speakers who exemplify the kind of innovative system thinking and reimagination of healthcare delivery that is required to meet the demands of a pandemic and to respond to the climate crisis. The examples they will share highlight the many co-benefits of climate-positive care, which have assumed a heightened importance in a post-pandemic recovery. Our first speaker is Timur Özelcel. He is a clinical professor in the Department of Anesthesiology and Pain Medicine at the University of Alberta, site chief of anesthesia at the Cross Cancer Institute, and director of quality and equipment procurement in anesthesiology for the Edmonton Zone. Timur is also vice chair of the section for environmental sustainability of the Canadian Anesthesia Society and founder of the American Society of Regional Anesthesia and Pain Medicine Green Anesthesia Special Interest Group. Sustaining a future for all life on the planet is Timur's primary passion in work and life, and his 3 children are the fuel that drives this. Over to you, Timur.
Thank you very much, Andrea, and thank you all for joining us here today. So first off, I have no conflict of interest to disclose to you, just a lot of interest that you are joining me today so I can speak to you to one of the topics closest to my heart in medicine, and as Andrea mentioned, to my private life. Well, Monday brought us the second part of the 6th assessment report of the IPCC, and the news was, as to be expected, very bleak. Well, the time for fruitless talking has passed, and we have to actively start tackling climate change. And as you can see from this picture in British Columbia last year, where 2021 has basically cycled through all the natural catastrophes of the 4 classical elements: air, earth, water, and fire. Some are already terming this to be the end of normal, and really my heart goes out to all inhabitants of the Pacific Coast, who arguably are some of the most progressive in North America, and probably will be the first and hardest hit by climate change. Well, meanwhile, in Alberta, where I'm from, this is what our premier had to say to Justin Trudeau appearing at COP26. I won't even deem to read this out to you. I hope you got it. The gist is that Alberta really wants to keep delivering its fossil fuels all the time. Now, one thing that we also got in the same week out of Quebec was some better news that they banned all new fossil fuel projects and extractions, and they also dropped oil production from its pension plan, which is the 2nd largest in Canada. Now, over to what I do, and that is anesthesia, and we'll look at what it does with climate change. Now, anesthesia is a necessity for modern day surgery. You could not do any of the surgeries we do nowadays without anesthesia, and the most common way of delivering anesthesia is with general anesthesia. And when I speak of general anesthesia, there really are four pillars to this, and that an anesthesiologist provides amnesia, meaning that the patient will not remember the surgery, hypnosis, the patient is asleep, muscles are relaxed, so they will not fight back or actively try to help the surgeon, and of course, analgesia, in that they're pain-free and will remember the surgeon, particularly very positively after the surgery. Now, the most common way to deliver general anesthesia is through inhalational anesthesia and the gas that they breathe. These are the three most commonly used, not only in Canada, but the Western world. The most commonly used sevoflurane, then desflurane, and then isoflurane. Now, we estimate that every year, 350 million surgeries are performed planet-wide. And if we just take some estimates out there in literature, we could say that anesthesia contributes around 150 kilograms of carbon dioxide equivalents per case, or 52.5 megatons annually of CO2 burden. And most of this comes from inhalational anesthetics, but they're all not weighted equally. If you look at this graph, you'll see in blue desflurane, and you can see that in the short term, so in the first few years, desflurane is over 100,000 times as potent as carbon dioxide. And even our so-called good inhalational anesthetics of sevoflurane and isoflurane are well towards 20,000 times as strong as CO2 as a climate forcer. In fact, if you look at a single operating day of desflurane used in a way that many people use it, well, you might as well, over those 7 hours, drive from the most northern point of Norway, the North Cap, all the way to the most southern point of South Africa, Cape Town, a distance of 16,090 kilometers. And when the Google Maps tells me that I would need to drive 208 hours to achieve nonstop. So 7 hours of OR versus 208 hours of driving. But even if we look at the best case option we have in the operating room, well, that's still like me driving from Edmonton to Regina daily. So there is a clear and present need for us to reduce the impact we create with anesthesiology. And now any change we make in medicine these days will most arguably have to follow the triple bottom line. Now, for those of you who have not heard this, the triple bottom line is an accounting framework meant to replace the single bottom line of profit. And in this triple bottom line, we consider the factors of people, planet, and profit equally. And if we use this Venn diagram and use the area they overlap, well, that's an area or a procedure that most likely will be able to be carried forward and that we'll be able to use for the long term. Now, we went out and thought about, well, how can we actually reduce the impact of our anesthetics that we do every day? And there are multiple ways to do this. I will not go into detail on all of them, but I will address one, what we call regional anesthesia, so blocking the nerves. And by doing this, we address the fourth pillar of the anesthetics, and that is the analgesia, meaning the freedom of pain. And if we can use a nerve block to free a patient from pain, arguably we should be able to use less anesthetic to keep the patient asleep. And so the hypothesis was that a patient who got a nerve block before surgery would need less anesthetic than a patient who got the nerve block after surgery. We did a double-blinded randomized controlled trial. And even though we had to cut this short because of COVID and only recruited around 50% of the patients we wanted to, we did see a significant result in that a nerve block was able to reduce the anesthetic we needed by almost 30%. And if we translate this into factors right now, taking, for example, numbers we have out of the USA, where we estimate about 500,000 rotator cuff surgeries in the USA with an average growth of 4% per year. In our series, we used around 77 minutes of sevoflurane, the gas, for our cases. And data of our institute suggests that we use of sevoflurane in the best case scenario around 10 milliliters per hour. And so for this specific scenario, if we used a nerve block, we would be able to save around 4 milliliters of sevoflurane per surgery. Well, that means for us that we now save in money, sorry, that was a little bit fast, $800,000 and about 10 million Canadian dollars where sevoflurane is a little bit cheaper. But for us today, maybe even more important is that we're now not emitting around 13 million carbon dioxides, which otherwise would have been used. And these 13 million carbon dioxides, if we just use this very simple calculator, are almost around 2,850 passenger vehicles that we are now putting on the street, or around 52.5 million kilometers not driven. Well, that's by reducing the anesthetic needed, but what if we could actually go without general anesthesia altogether? And so we explored one surgery. So ocular brachytherapy is a surgery by which a radioactive plaque is sutured onto the eye by an ocular surgeon and remains there in place. This is a surgery that we have always done under general anesthesia at the Cross Cancer Hospital in Edmonton. So we decided, well, let's try this without general anesthesia. So the surgeon provided local anesthesia up front, and I kept the patients asleep with an intravenous sedation. They were fully asleep, so this was not a sedation like in colonoscopies, but I had them asleep and sleeping throughout the procedure. And so we did this for 13 days. We do 1 day a month, so 13 months of this therapy, and compared it with the immediately preceding 13 months, all of which cases were done under general anesthesia. Same surgeon, but a few different anesthesiologists, but every single one of us did general anesthesia. And so the results show that patients were discharged around 1.5 hours earlier, which is significant for a day surgical case. And we also saw that we were able to do almost 1 surgery more per day. And this also in the whole time had less overtime for staff. Now, if we look at our climate factors, well, the biggest thing is, of course, that we have decreased resource utilization and we avoided general anesthesia altogether. And our patients, I will not show you the data here right now, but they were overwhelmingly happier, had much less nausea and vomiting. So overall, we addressed really all 3 elements of the triple bottom line and found this so successful that we expanded this project. And then next, our primary thing that we do nowadays is that we do all breast conserving surgery with or without lymph nodes for breast cancer. But we even do full mastectomy, so a full amputation of the breast with or without lymph nodes resected from the armpit. And we do this with a nerve block. We also do gynecological brachytherapy. So this is a radiation procedure for women. We also do surgeries of the vulva and perineum and surgeries of the anus and rectum. And last but not least, in Edmonton, we have a major burn center. So we do all the burn scar lasering without general anesthesia. And all of these 6 categories were surgeries that we always did under general anesthesia. So we are dramatically reducing the impact we create, because ultimately it really starts with us, right? What can I ask of this guy staring back at me in the mirror? It really starts with us wanting to make a difference. And ultimately, I'm happy that the Conference of the Parties is taking place, but it will not be enough to just rely on others to do this for us. And so I will close with the words of the King of Pop. They're from the 80s. I'm not sure if he wrote them himself, but whoever it was ahead of their time. Thank you very much, and I'll return it to you, Andrea.
Thank you, Timur. Next, we'll move on to Dr. Philip Wong. So Philip Wong is a radiation oncologist at the Princess Margaret Cancer Centre, University Health Network in Toronto. He's also assistant professor in the University of Toronto Department of Radiation Oncology, associate member of the U of T Institute of Medical Science, affiliate professor in the Department of Radiology, Radiation Oncology, and Nuclear Medicine at the University of Montreal, an affiliate clinician investigator for Cancer Access at CRCHUM in Montreal. Philip's creative professional activities revolve around sarcoma patients and those undergoing palliative radiotherapy. Philip is currently evaluating the use of wearable technology to monitor treatment-related toxicities so as to further enhance the safety of patients undergoing combined modality treatments. Thank you very much for being here. Over to you, Dr. Wong.
Thank you, Andrea. So thank you for inviting me to this platform. This is very exciting. So I'm Philip Wong. I'm a radiation oncologist working at the Princess Margaret, and will be presenting to you some of my ideas about radiation treatments. So what brought me upon this is basically that during COVID, and during the first wave of COVID in particular, there was a drop in the amount of people walking around the street or bicycling or even particularly driving while I was still having to go to work. And that gave me lots of time and freedom and space to look around me. And I was particularly enchanted by seeing a bit more wildlife, breathing fresher air, and having the time and space to think a bit more without having to worry being run over by cars. So that basically got me thinking, so what are we doing in radiation oncology? What is our environmental impact as a program? And how did COVID and its subsequent tangential effect affect our carbon footprint as a department overall? For those of you that are interested, basically what I want to do is to better define what is our department doing overall when it comes to carbon footprint. On the left, I've asked the AI art generator to basically draw me something that has to do with carbon footprint from radiotherapy in humans. And this is after 50 iterations, and this is after 600 iterations. We better see We see better the machine that we give radiation to with a CT scan of the patient's lung and a small tree growing out of it. So hopefully I can accomplish some of this and better define what we are doing in our department. So our project was called Steer COVID-19, and basically to look at the short-term environmental and clinical effect of our program in response to COVID-19 pandemic. During the COVID-19 pandemic, our department had three main response mechanisms to deal with the pandemic. One is that we allowed more staffs to do remote work. Two is that we implemented virtual care across the board. Three is that we used more intense radiation treatments so as to shorten the amount of time that patients will have to come to the hospital for their treatments and reduce the amount of travel and thereby reduce the risk of contacting COVID as well. So our primary objective was to look at the environmental impact of these strategies in terms of carbon footprint. Our secondary objective was to look at the clinical impact of these changes. How are they affecting the patients in terms of toxicities and side effects? So before I get going with this, let me give you a brief overview of how radiation works. So after a patient has seen us in consultation, and if they're eligible for radiation treatment, they come and do a CT scan, the so-called CT simulation scan. We acquire a virtual patient in our system, and our dosimetrists and physicists then work on this virtual patient and pump out a plan to treat the patient. When the plan is ready, the patient is called back and they undergo a course of treatment. This course of treatment can last from one treatment all the way to 40 different treatments on 40 days. Subsequently, they're discharged and they're followed up in our practice as per standard of care. So what we did, firstly, is that we measured the patient traveling distance from home to the Princess Margaret. And we basically we created a script on Google Maps and we calculated individual patients as they travel through to our hospital center, and based on the number of treatments they had to go through and the number of visits that they had to go through in person. We then converted all that into CO2 using the three most common cars and their CO2 output based on distances. We then looked at our linear accelerator, which is basically our main modality of giving radiation to patients. And what is their power usage in terms of CO2 consumption? And we basically matched the time and date of each patient's treatments with the CO2 generated at the time per watt as published by the Ontario Grid data. We then looked at basically PPE usage and how are they affecting in terms of our CO2, our carbon footprint as a hospital overall during this pandemic year. Finally, as I was saying, we measured basically the serious adverse events and toxicities incurred upon these patients. Basically, we were looking at how many of these patients were going to the emergency or the radiation nursing clinic, which is a pop-in clinic, for any adverse events the patients have within their course of treatment or within 90 days of their treatment completion. So this is the data that we had. We collected data from the 10,175 patients that were treated during the year before COVID, named as 2019 to 2020 fiscal year, and the year during COVID, 2020 to 2021 fiscal year. 14,000 courses of treatments were given to these patients. And basically, in terms of the use of hypofractionation, there was more use of hypofractionation or the more intensified treatment across the board in all cancer types in the year when COVID was occurring, both in the curative setting and in the palliative settings. Basically, in the curative settings, there was a 10% increase in the number of patients that were treated in the more intensified course of treatments. When it comes to patients that were seen in person or virtually during the 2 years, one can see that during the year before pandemic, the use of virtual visits was irrelevant, basically, whether for consultations or for follow-ups. But during the year of pandemic, about 40% of our patients were seen virtually for consultations and for follow-ups. So that was a large shift in the pattern of care for patients and patient management. Our institute has a large catch area, and we provided treatments to patients far across the Ontario province. And if we zoom in, this is basically the Greater Toronto area that is basically serviced by our transit system. And 50% of our patients come from this area, and in STAR, this is where our institution is. 75% of our patients come from either this area or the Hamilton area right next door. In summary, what we found is that during the pandemic year, there was a reduction of about 740,000 kilograms of CO2. Most of them came from a reduction in patient travels, a third of which came from the intensification of the treatment, leading to less patient travel to our hospital for treatment purpose. About 2/3 of them were due to the implementation of virtual care, so patients don't have to travel to our hospital for in-person visits. The use of linear accelerator, despite reduction and intensification of the treatment, didn't really change too much in terms of the CO2 output. The use of PPE, though, did probably increase the use of our carbon footprint by about 6,700 kilograms of CO2 during the year of pandemic. This basically represents a reduction of 39% in our department's carbon output during the year of pandemic. Now, when it comes to toxicity, we want to measure that because despite the fact that potentially we are reducing the CO2 output, we want to make sure that we're providing safe and good quality of care to patients nevertheless. So what we see here is basically patients going to the RNC, radiation nursing clinic, or the ER. What we found is that there was a significant reduction in the patients that were treated with hypofractionation and showing up at the radiation nursing clinic or the emergency. What's strange, though, and potentially not strange, is that there was an increase in the number of patients treated in the conventional way and showing up at both at the radiation nursing clinic or at the ER. There was a potential bias in here in that probably radiation oncologists felt that the more fragile, more frail, or more advanced stage patients were kept under the conventional way so as not to further intensify and fragilize the patient. And therefore, in relative terms, these patients were kept in the conventional way and were showing up more with toxicities. So what have we learned? We learned from our study that there was an environmental benefit in the use of hypofractionated regimen and virtual care in our system. We did not see an increased amount of acute radiation-related side effects. We think that this study supports the continued use of hypofractionation and virtual care as a long-term strategy to reduce our environmental footprint in healthcare and particularly in radiation oncology. So what can we do from here onward? Well, one of the things that perhaps we can see from here is that even though now COVID is receding, we are seeing more and more patients, car traffic has ramped up again back to almost pre-pandemic level, the use of public transport has not. And if the majority of the CO2 footprint from coming to radiation is due to transit, then is there a way we can motivate patients to come and utilize public transit more often? How can we make public transit more accessible to patients who are frail with cancer? And how can we tell them that it's safe, even though you're having cancer treatment and you're immunocompromised, to take the public transit for your healthcare? Another way potentially is that here is the Ontario map once again. In STAR, you can see the area, the hospitals whereby radiation treatment can be delivered across the Ontario map. Well, we understand that tertiary centers are built so that they can have some kind of expertise in treating more complex and possibly rarer diseases, whereas community centers may not have as much resources. But what if we were able to do this in cloud and hopefully join up together so that we can democratize radiation treatment and care? Perhaps the tertiary centers can have a more live way of interacting with the community center and guide them to give as good as of care at the community as in the tertiary center. So going back to what can we do, I think what we are hoping to do is that we can continue using hypofractionation. We think that it's relatively safe to continue to do that. We hope to continue virtual care, and I think it is here to stay. It's not going away. But we hope that we can deliver better virtual care and safer virtual care to patients and potentially to more patients. We want to continue evaluating the long-term impacts of these changes because we want to make sure that it's safe and high quality and that the efficacy, which comes in years later, is as good as it is before the pandemic. We want to measure the other scope 1, 2, 3 output from our institution in order to have a better delineation of what we're doing. And as an academic institution, we're here to explore and innovate. So we hope to basically use our brains together, put our brains together to look at new technologies and how can we utilize them for a more sustainable healthcare. Thank you.
Thank you very much, Dr. Wong. I would encourage the participants to put any questions for our speakers in the chat on the YouTube channel, and we'll reserve question time for the completion of our third speaker. So right now, we're going to move on to Darcia Pope, one of my colleagues. Darcia is Vice President and Chief Transformation Officer at Vancouver Coastal Health. Darcia oversees the strategic and operational planning processes, supports the measurement and realization of benefits and outcomes for enterprise-wide initiatives, and leads the innovation portfolio. Darcia identifies key strategies and ensures a robust process is in place to remove barriers quickly and effectively ensure initiatives remain on track and that they move to completion and are aligned with the organization's strategic priorities and long-term financial plans. Darcia is leading our planetary health strategy development for VCH, and she believes that our health professionals have a tremendous opportunity to protect our clients from the impacts of climate change by working to create sustainable, climate-smart health systems. Thank you, Darcia.
Thank you so much, Andrea. Thank you for the lovely introduction, and it's a thrill to be here. My perspective is a little bit different today because I think really my role as the Chief Transformation Officer is to help enable clinicians like Timur and Philip be successful in all of the wonderful work that they do in their organizations. So I'm going to start my presentation by acknowledging that I am also, in addition to Dr. Andrew McNeil, joining you today from the traditional unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations, and very, very grateful for that. So I thought today, as I walk through the presentation, that I would walk through it from the perspective of first, the overall strategic planning process within the organization, as I really think that has been quite critical for us in determining our commitment and the visibility to that commitment for our planetary health agenda. So I'll talk a little bit about the evolution of that work and where our overall commitment to the environment exists within that framework. I'll then talk about what we are doing to embed our planetary health mandate and commitment into everything we do in the organization. And then I'll speak a little bit to some of the work underway in terms of engagement and innovation with all of our staff, medical staff, and key partners. So when we look at our Vancouver Coastal Health Strategic Framework, we work together with our board and our senior executive team to really map out our key strategic goals. And we really landed on 3 goals: exceptional care, high quality, culturally safe care for the best health outcome in the best setting, hospital, home, or community; innovation for impact, evolving how we deliver services to stay at the forefront of healthcare; and great place to work, coming together as a collective healthcare team to build a better workplace. So when we went to the next phase to think through our core strategies, it was very interesting how the discussion around our commitment to planetary health evolved, because it is really one of those key areas of focus that we at our organization call the triple word score. It's absolutely fundamentally a key strategy in exceptional care. We know we need to reimagine the way we deliver services with both our human impact and our environmental impact in mind. And we know we need to innovate in order to do that. And we know one thing that people care about more than anything else is our impact on the environment, our commitment to sustainability. We know it's also core to recruitment and retention and to building a better workplace. So much of the debate was, where do we put planetary health? Which one of these 3 goals? And as that discussion unfolded, we all agreed that really at the top of our pyramid is our commitment to exceptional care. And innovation for impact and great place to work are really those enabling goals to help us be successful in the way we deliver care and services to our population. So we added build an integrated strategy and plan for planetary health under our exceptional care goal about 2 or 3 years ago. So while I say only 2 or 3 years ago, our commitment to environmental sustainability has been long-standing, and there's been lots of work happening within all different areas of our organization. Lots of work in looking at our facilities team, our energy and environmental services. We were probably one of the earliest organizations establishing a green care team and focusing on Green Plus leaders around engagement. But this is a different level of commitment once we start to articulate it visibly and transparently as one of our core goals. This now means that the board and the senior executive team, as well as the Ministry of Health, are prepared to put resources and target our innovations to moving this agenda forward. So in this last year, many of those goals and strategies really ended up being put on pause while most of our resources in the system were focused on our pandemic response. That was our key focus over the last 2 years. And really, it gave us great opportunities in many ways to redesign how we deliver care, to innovate in how we do that, and to really come together as a healthcare team across disciplines and across hierarchies and across geographies, probably in a way we never have before. So as we started that pandemic response, as everyone had in place across the globe and continues to have today, we all of a sudden found ourselves standing up a second emergency response to respond to the climate events. And this is the first time that we've been impacted to the degree in BC that we were impacted this year. And you started to see the obvious interconnectedness and interdependencies between the impact on our patient population of COVID and the impact on the health of our population in these extreme weather events. And you could see that we needed to care for both humans and for the environment concurrently. So I think one thing we really learned as an organization became more apparent to everybody is this is not a separate agenda. This is not a separate stream of work that one team in our organization is working on environmental sustainability. This is part of the fabric of our organization and needs to become a part of every single thing we do. So some of our most extreme events, I know Timur, thank you for acknowledgement of the impact. We looked at our highways being flooded, which was something no one had anticipated would happen in this time frame. And one of the activities that I was involved in was looking at how do we evacuate long-term care residents from the interior of BC down to Vancouver. Now at that time, it was due to our wildfires prior to the flooding. And those wildfires were putting our highways at risk, in addition to our long-term care facilities at risk. For the first time, we were looking at how do we evacuate long-term care residents by air from the interior down to the Vancouver for an undetermined amount of time. And it really just started to open up those conversations around how much more prepared we need to get around being able to be prepared to respond to climate events, in addition to trying to minimize our negative footprint as an organization. So I think as part of our planetary health, there's opportunities, but it also had some setbacks. So similar to what some of the things that Philip just articulated, virtual care and virtual gatherings and meetings, huge amount of opportunity there. We saw lots of benefits, reduced travel, both patients and staff, supply chain resilience with our dependency on PPE, that became more important than ever before. We've actually never had supply chain mechanisms that get supplies out to our long-term care and community sites the way we needed to. They were primarily focused on our acute care sites. Also, when we looked at the supply chain resilience required to get the vaccines to all of our different locations globally, into Canada, into BC, and into all of our sites, huge strides were made. Expanded community preparedness and resilience, and it accelerated collaboration across teams, departments, organizations, and sectors. And for us, I think this is really one of the most important things that we have to build off as we all work on this together. We know some of the setbacks when we look at the infection prevention and control procedures that had to be put in place and the cleaning that was required, that we've had increased waste and disinfectant use. We also know we've had many single-use products as we've had to move through the pandemic response, as well as reduced use of sustainable transportation options. So now it's really, really important for us to think about what do we take from our learnings in the pandemic and build on, but what areas actually took us backwards, and how do we make sure that we now reframe and move forward in a different way? So I think it's time for us as a healthcare organization and a healthcare provider. It's both our responsibility and our opportunity now to look at how we start to move forward from here. And healthcare systems are uniquely and strategically positioned at the intersection of human and environmental health, which, as I said, is more evident than ever before. In both areas, our mandate is first and foremost, we must do no harm, but we know we have so much opportunity to do so much good. So I think we're looking at what are the cascading benefits of stepping into the role of being an anchor institution. How do we as Vancouver Coastal Health really start to lead the way and really start to take on some of these big challenges around looking at circular supply chain, around looking at completely redesigning the way we're building our facilities to support totally different ways of delivering care? How do we start to be able to set the stage and collaborate and bring other partners along? We do receive a mandate letter from the Ministry of Health each and every year. Our commitment to climate change as a province is called out clearly within that mandate letter. It is now one of the foundational principles that all health authorities are expected to deliver against. But what's legislated to us is not enough. The targets are still around our emissions, our energy use. We know we need to be more ambitious. So our goal is really to achieve all of those mandated deliverables and also look at how much more and how much further we can take our organization. So I'll talk a little bit about some of the examples around how we're embedding our planetary health mandate and commitment within our organization. As I said earlier, we have had a lot of work happening for many, many, many years, and want to acknowledge that we've had teams that have done incredible things. So we kind of think of it as the three key legs of a stool within Vancouver Coastal Health. The first stool I have there is the first leg is the energy and environmental sustainability team. Really, the focus of that team has been ensuring sustainable and resilient facilities, reducing emissions and waste, and reducing our risk and vulnerability to climate events. That team has been doing incredible work for well over a decade, and not only working with Vancouver Coastal Health, but also working across health authorities within the Lower Mainland. They're also the team that established our Green Plus Leaders program to gain engagement at the front line very early on. On the far right, the Healthy Environments team, which is a part of our Chief Medical Health Officer public health portfolio. And you saw three key members of this team present at a Cascades webinar. I think it was just last week. We had Dr. Michael Schwand, we had Emily, we had Craig, really doing what I would call a deep dive into that leg of our school to understand climate adaptation and the work that that team is doing to support the health of our populations through minimized environmental impacts and resilience to climate events. And our newest, biggest focus leg in the stool, I'm thrilled to say the Sustainable Clinical Services team is where Andrea McNeil has just been appointed as our first medical director of the Planetary Health Program across Vancouver Coastal Health. So this is a new role for us. It's also a new portfolio for us to be able to expand and resource the focused work with our clinicians to ensuring sustainable service delivery by shifting to a reusables first approach and appropriately matching supply and demand for service, and really looking at that clinical appropriateness lens within our organization. So when we use the term planetary health, we kind of think of that seat on the stool that not only encompasses and helps to integrate and support all of those teams' work, but then what is actually the role for each and every one of us in terms of us building it into our strategy, making our commitments, making sure we're applying the resources required to move forward successful, and engage and innovate with all of our staff and medical staff as we move forward. Some of the framework that we use in our organization, the beginning frame, the focus was mostly on environmental sustainability, reducing negative impacts on the environment. We then kind of shifted more to the right over the last couple of years around climate resilience and adaptation, reducing risk and improving preparedness for what we know is going to come based on our behavior as humans already to date. And now our opportunity is like, where are those overlaps? How do we take a more systematic approach for things such as new energy systems, local food systems, low carbon resilience are just examples of some of the areas of focus that start to overlap across those spheres and start to create the need for that planetary health seat on the stool, knowing that it's everybody's work and there's no one team that can do this alone. So in taking this framework for planetary health from Dr. McNeil's article in Lancet, it's the whole system approach that helps people see that they have a place in us redesigning the way we deliver care and taking more responsibility, whether it's in reducing demand for health services, whether it's in matching supply of health services demand, or whether it's reducing emissions from supply of health services. There's a role for everyone in our organization and everyone that we partner with to make a difference in this space. So when we look at sustainability and services, the areas that we begin with are the areas that were a little bit easier to tackle in terms of just defining the scope of the work and how we get started. And I think that's why we had such great and quick progress around engaging Green Plus leaders, around rolling out recycling programs, waste reduction workshops, composting programs across all of our healthcare facilities, much more quickly than many other health organizations were able to do. In addition to a lot of energy-wise campaigns, carpooling programs, establishing bike racks all over the campus, all of these types of things were where we started to initiate. Now where we're at is where do we need to collaborate with multidisciplinary, cross-department, cross-hierarchy teams to start to make some other areas of difference that require a lot of different stakeholders to work together. We're looking at how to integrate in quality and safety, patient safety metrics. We're exploring opportunities with contract food services, housekeeping, and waste management, which is our business initiatives and support services team have done phenomenal work, especially in the area of food services and reduction of waste. Working with our supply chain teams and exploring environmental preferable purchasing, looking at who we start to contract, how we start to write what our procurement policies and strategies are. Environmental metrics to measure reduction in emissions and PPE use. And really reducing food waste, strengthening local food systems, and improving patient outcomes. Some really incredible work done through our hospital food transformation project just recently. So clinical emissions, we know, are a big area of opportunity. And this is much why we're building out that third leg of our stool. We really need to be able to work together with all of our clinicians in the organization, looking at the impact of clinical decisions, the way practices are organized, investigations and treatments, how they're ordered, what products are used. So COVID is really forcing us to look at supply chains and material use in a totally different way, a dual opportunity for mitigation and building resilience. So this is a huge area of focus for us moving forward as we really start to look at circular supply chain. You heard a little bit from Dr. Schwand and Emily and Craig last week, if you were on that webinar, around our seasonal readiness preparedness. I'm not going to go into detail there, but I think it's just another example I wanted to highlight with a huge number of different knowledge and expertise and resources across our organization. So we have a seasonal readiness committee established with very detailed plans on how are we going to protect our patient populations and ensure our ability to deliver service is resilient even in extreme weather events. So we have all of our regional programs focused on home health, acute services, mental health and substance use, our vulnerable homeless populations, and detailed plans on how will we care for those populations and make sure our ability to deliver that care is resilient when we do have extreme weather events. So a couple of quick comments on engagement and innovation. I want to make sure we do leave time for questions, so I will keep moving along. But I did want to share, because I think this is also critical, that in addition to our strategic priorities, we also talk about what are the key foundational lenses that I kind of call it, we want to wire into the DNA of every single person who works with and for Vancouver Coastal Health. And those things that we put forward are putting people first, caring for our clients, caring for each other, caring for ourselves, lasting and meaningful reconciliation, tackling diversity, equity, and inclusion and anti-racism, a better future through fighting climate change, and a leader in research and innovation. So we know these things are all interwoven, they're not separate and discrete, and they're all absolutely critical for us in the culture that we're trying to create at Vancouver Coastal Health. So like I said, we've had the Green Plus Leaders program in place for many years, and people have loved the opportunity to engage. And now where we're taking that is to a shift that focuses, I would say, a little bit more on innovation rather than just engagement and communication. we just launched a new Spark platform, which is an innovation platform that allows you to come together as a community, pose a challenge, have people crowdsource and build on each other's ideas, vote on different ideas, and look at implementing some major change based on the voice of the community that has been asked together to help solve the problem. So we did one with the green care leaders to look at the difference we could make in terms of planetary health in BC. And Andrea also led one with our OR team together with the operations leader, really looking at how do we reduce our footprint within the operating room. So just a couple of examples where we're taking engagement to innovation, all for the benefit of improving our ability to focus on the planet and the health of the planet. So thank you very much, Andrea.
Thank you, Darcia. That was amazing. That makes me very proud to work for VCH to see it all encapsulated like that. Thank you so much for joining us today and offering your very unique perspective from the senior leadership role. So we're going to open it up for questions now. If you have a question, just drop it into the YouTube chat. And while those are accumulating, I'm just going to start with one of my own, which kind of has applicability to all of the speakers here. So I have noticed an interesting and disquieting trend in that I think people assume that the way we did things before the pandemic, or generally business as usual, is the result of some sort of carefully thought out master plan, and that it was necessarily the best way. And there is an enormous amount of resistance to changing that status quo. And both Timur and Phil showed us examples of pandemic-driven innovations with multifold benefits that, as far as I can tell, have no downsides or are clearly superior. For Timur and Phil, can you tell me what would it take for those to become standard of care? And Darcia, can you try to shed some light on why there is such resistance to changing from business as usual to this type of clearly win-win-win innovation? So Timur or Phil, do you want to respond first from your clinical perspective?
Yes, I'll be happy to maybe start, and then I'll be very happy to pass over to Phil. So first off, the things that I have been describing have become a reality within the Cross Cancer Hospital, where I'm the site chief and obviously have most influence. One thing that obviously we will take is data, and we are probably very close to publishing wide sweeping data to show the benefits, at least right now, first and foremost to our patients. And then maybe in the next step, we will apply for the funding to be able to fully analyze the environmental benefits that go in with this. I feel, that once again, it really goes down to what I said in the end. You'll have to try to build bridges where there were none before. Okay. And a lot of people are very hesitant to overcome, I'm not even going to say prejudices, but to learn of importances of things they never placed importance on before. And I think also one thing that maybe Darcia can comment on when she's on is how will we avoid the wave that has completely swept the United States, something that is being driven by industry and trying to force us into polluting more, into wasting more, into destroying more. How do we stop that from, first of all, reaching Canada, but also undo some of the things that have already taken roots here, like pharmacy, for example, mandating that we dispose of any opened or partially opened medications, even though they're perfectly clean and could be used for other patients. So there are lots of things that I totally agree. We cannot go back to business as usual, but needs to basically see it as almost a golden opportunity to build de novo. And yeah, so from my end, we're trying that in Edmonton, and hopefully if we reconvene after COP27, I will already be able to tell you lots more positive news.
Good. Phil, what do you think it would take for hypofractionation to be standard of care?
I think this is, it's almost like a crux of medicine, in that we typically want level 1 evidence, randomized controlled trial with thousands of patients before we take it up and say, okay, this is the new standard of care. And in doing these trials, it takes forever. And then the uptake after these trials are done takes a decade easily to be implemented in full action across the entire community. While this is great for safety purpose, it's not really good for innovation and pushing things forward. And I think what Timur mentioned is really sort of what the UN resolution and the New Frontier Grant is trying to push for is that we should not be going back to business as usual. We should really push for innovation and a new beginning. And this is what they are trying to push forward with regards to the funding, is that we want to see new ideas, new ways of doing things that completely breaks from tradition, because we already know what back to business as usual is about. What is the alternative? So hopefully this is going to be a new way of thinking and generate new enthusiasm and a little bit of risk taking, but that would accelerate the pace at which we would actually move forward.
Great. And then Darcia, do you have any insights about accelerating innovation within the patient safety and quality paradigm?
Yeah, no, I really appreciate the comments. And I think part of it was the burning platform and the common goal through the pandemic. That for us, you could just see the way it rallied people together, and it forced a real innovative mindset in terms of the types of things we were prepared to try, and looking at the risk benefit ratio and trying and improving and going, because it didn't have a choice of business as usual in the moment. And so it had to be something different, and it had to be something new, especially in those first 3 months when we were shutting down almost all of our services outside of caring for COVID patients. And we knew we still needed to find ways of caring for everybody else. And so I think the very optimistic and hopeful part is, I think people saw so much value in how much we can reimagine how we deliver care. It's very obvious that we can't do things the way we've done them before. We'll never get enough human resources to continue to deliver care to the growing population that needs our service the way we do things now. So I think the combination, when I look at the climate crisis that was right in front of us in BC this last year, when I look at the need for this unbelievable innovation and a different way of thinking and collaborating and appreciating different skill sets and expertise in coming together quite quickly to make a big difference. And then when I look at now, one of our biggest challenges is the human resource shortage. As we're coming out of our pandemic, one of our biggest challenges is we cannot recruit people, thousands of vacancies within the organization. So if that's not a driver for innovation, when you don't have the people to deliver the care in the same ways. So I think there are a lot of things that are going to drive a new way forward. But a lot of that, to Timur's point, it just requires so many large stakeholders. When we look at the pharmaceutical services, we look at the Ministry of Health and our provincial and federal governments and some of the kind of rules, the policies, the procurement requirements, the funding models, everything has to change in order for us to make big changes in innovation. So I really hope the appetite is there coming out of the pandemic, and I feel like it is. I think it's an exciting time forward.
Amazing. Now, Darcia, following up on that, you mentioned the ministry, and we have a question from Fiona Miller asking if you can speak to how the ministry influences and supports the work of the health authority in relation to climate positive care.
Sure, I can absolutely do that. So I think maybe I'll just start by saying that the role of the Ministry of Health and then the health authorities, the ministry really is setting out what we call the mandate letter, which sets out the expectations of what we as the health authority are expected to deliver. One of the core tenets within that mandate letter is around the commitment to climate change and sustainability. Most still of the metrics and targets that we receive are around our emissions, around our energy use, around looking at some of the toxicity in our water levels. We have a whole bunch of metrics. They're mostly in the energy and environmental services space. So I think there's a lot more opportunity for us to be able to collaborate with and work with the Ministry of Health, actually to be able to hold all health authorities accountable, including ourselves, to a higher standard of what types of changes we should be able to make within our organization. A lot of it's also focused on our facilities, the expectation of any new build within our facilities in terms of gold standards and other types of requirements. So I think the ministry is starting. I think the ministry is committed. I think also we have an opportunity to really have us held to a higher standard as a health authority.
Thank you. Darcia, you're very popular in the chat. This next question is directed to you as well, although I think I can answer part of it if you like. Maddie Charles is asking, Could you address how VCH and their work could or should be implemented within Canadian health policy? So I think maybe just sort of a spreading and scaling question. And I would use that as an opportunity to plug Cascades, because this network exists specifically for that purpose of certainly accelerating the uptake of validated innovations within sustainable healthcare. So hopefully everything you just described will become more accessible to other health systems across the country through this particular knowledge mobilization network. But do you have any other suggestions as to how we can get this out there and make it more accessible to other health systems?
Yeah, no, it's a really good question. And I think it does require a lot more thought around how do we start to share and spread and scale. And I think one of the reasons why I just love to continue to make the connection between innovation and planetary health is because I think it's the innovations in terms of how do we change the way we deliver services to have a better impact on our planet that we can spread and scale. And there are actually a lot of organizations, like we're a member of the Can Health Network that is looking at how to spread innovations all across the country. There's an opportunity to give way more profile to planetary health in that space. I know I sit with my colleagues on Innovation Advisory Council with the Ministry of Health. They're looking at how do they actually start to design innovation networks and hubs that focus on planetary health and climate change. I've got discussions underway with foundations and other partners around how do we start to think differently about how we raise money in terms of the types of things that we need to do that maybe we don't actually have enough funding within our health authority alone to redesign and make those kinds of changes. So I think there's different opportunities to spread and scale. At the same time, I think we're still just getting started from that perspective and have a lot more to learn.
Excellent, thank you. Now, I think we have time for one final question. So I'm going to put to both of our clinicians the general question that both of the innovations you described were instigated by the pandemic, by avoidance of aerosols in the case of uptake of regional anesthesia, and Phil, obviously the need to avoid interacting with the healthcare system and travel for yours. What other opportunities do you see emerging from the disruption of the past couple of years that might have these same triple bottom line impacts? And then I'll add to that Timur, in the chat, there's a specific question to you about the potential for change in anesthesia across the country, and what do you see as the biggest opportunities there?
Well, thank you. So first off, to answer the last question, there is much we can do, and anesthesia is extremely low-hanging fruit. Practice changes like avoiding desflurane could already reduce the impact by around 70 to 80%, where we, with one little swipe, could already fulfill the Paris Climate Accord agreements, that we've entered to, at least from an anesthesia perspective, but there's much more we can do. I think ultimately, going back to your first question, what do I hope that the pandemic can teach us? Well, the pandemic can teach us is, if we look back into the beginning, what Darcia was also talking about, the first few months, in that we all of a sudden had to change from business as usual. For example, we did not have PPE, we did not have all these other things that we did use before, and we got by just fine. I think we have to maybe start reconsidering a little bit why we were doing all this in the first place. Okay, is this something that is truly beneficial to our patients, or is this something that we're led to believe is a necessity in healthcare? And once again, markets driven the whole thing. And so I believe that we have tremendous opportunity in starting to ask new questions altogether instead of trying to find answers or different answers for existing ones.
Thank you. And Phil, do you have any triple bottom line opportunities?
I don't have any straightforward answer for you, but perhaps one of the things that was opened up during the whole COVID pandemic is perhaps the question about equity, diversity, accessibility to care. And I think that really had pointed out to us what are the deficiencies in our healthcare is. And when, I want to integrate more virtual care, that's great. But if patients don't have access to broadband internet, don't have the time to come back and forth to the hospital, or have other issues in accessing healthcare because of all the COVID-related restrictions and everything, then we are basically not fully serving our population. And hopefully in improving that side of things, we can actually provide a more democratic way of giving healthcare to patients. And equally, we may have a more sustainable model of delivering care that way.
Beautifully put, and an excellent note to end on. I want to thank everyone for joining us today, and in particular, our three brilliant speakers. Now, while this was the last of our 3 webinars planned for this series, we invite you to continue these conversations in the Cascades Forum and in our monthly exchange events. You can also check out the Cascades event page for information about upcoming opportunities. Kate is going to put links to each of these in the chat now. And there's also a post-event survey posted in the chat that will go out by email as well to everyone who pre-registered. So thank you again, and have a wonderful rest of your afternoon or evening wherever you are. Thank you.
Thank you, Andrea.
Thank you. Goodbye, everyone.